high subtrochanteric fracture with a suspected intertrochanteric element being treated with TFN. The preoperative picture in a 75-year-old lady. Intraoperative pictures on a orthopedic traction table. As we were suspecting intertrochanteric element also, two K-wires were passed very anteriorly to fix this part. This will also help in preventing blowout of the proximal fragment while we are reaming. Entry done with a guide pin. Before that, a Steinmann pin has been passed in the proximal fragment to adduct and internal rotate so that the teardrop piriformis entry can be seen well. These are the steps of passing the guide pin. Over the guide pin, a curved cannulated awl is passed. This helps in keeping the guide wire as lateral as possible in the proximal fragment. The guide pin is removed and a long flexible guide wire being passed. Then with a 15 millimeter centering awl, proximal fragment reamed to accommodate the 15 millimeter proximal end of the nail. Here you can see that K-wires will help in preventing blowout of the greater trochanter. Then nail was passed. Guide wires for the neck screws have been passed. On the right side, the view what you can see is almost 45-degree oblique as the jig was coming in the way. It's not a true lateral picture, but it shows that guide wires are in the posterior part of the head and neck. Once the guide wire position was confirmed, neck screws have been passed, the superior one first and the inferior one. Dynamic distal locking carried out after releasing the traction and adequately compacting the subtrochanteric fracture element. These are the final AP and lateral picture. As you can see, the derotation screw is touching the lateral cortex, which was intact at that site, but the cervical screw was at the fracture site. Hence, it has been pushed through the fracture site so that the head of the cervical screw is resting against the nail. The nail acts as the lateral wall. These are the distal part pictures showing there is no impingement. This is the preoperative and immediate portable X-ray in the OT showing a good valgus reduction. The nail is proud proximally. We could have used another nail which is 15 millimeter shorter, but this company, the nail whatever I have used was of only one size proximal end, so that was not possible in this case. Thanks to Dr. Adarsh Mehta from Sholapur for this case. Thank you all for watching.